Hi, good afternoon, everyone. Thanks for joining us. I'm Sarah, Key Account Manager from CordLife Singapore, and I will be your MC today. On behalf of the CordLife Group, I would like to extend a very warm welcome and special thanks to all the doctors for attending today's CME webinar. We have doctors from different countries, including Singapore, Hong Kong, India, Indonesia, Malaysia, Bangladesh, and the Philippines. We would like to specially thank Singapore OGSS, Malaysia OGSM, Hong Kong College of ONG, India FOGSI, welcoming President Dr. S. Shantakumari. Thank you for your support of our CME webinar today. Before we begin, let me just run through some operational points for today's seminar. The session will be recorded, and as you may have noticed, all attendees are on mute. If you do have questions for us though, please click on the chat button at the bottom of your screen and enter your questions. You can do this at any time during the meeting. We'll address the questions during the Q&A session at the end of the meeting, and similar questions will be addressed together. We appreciate your kind understanding that we may not be able to answer all questions due to time constraints. Now, let me give you some latest updates on our company. Since we were founded and established in Singapore in 2001, CordLife Group Limited has been dedicated to safeguarding the well-being of mother and child. Our group has been listed on the Singapore Stock Exchange since 2012, and we are proud to be a pioneer in private cord blood banking in Asia. Being the largest network of cord blood banks in Asia, we have more than 500,000 cord blood units entrusted to us in Singapore, Hong Kong, Indonesia, India, Malaysia, and the Philippines. Additionally, CordLife has also established presence in Thailand, Myanmar, Vietnam, Macau, Brunei, and Bangladesh. We are very proud to be the largest cord blood bank in Singapore, Hong Kong, Philippines, and Indonesia. Beyond cord blood, cord lining, and cord tissue banking, we offer a comprehensive suite of diagnostic services for the family, including non-invasive prenatal testing, like NICE, pediatric vision screening, newborn metabolic screening, and family genetic screening services. As a commitment to quality, all of the facilities under CordLife Group are accredited by AABB or both AABB and FACT, which are the world's gold standards for cord blood banking. Since we have expanded our business to include clinical diagnostics, CordLife India, Hong Kong, and Health Baby Hong Kong are accredited by the College of American Pathologists, or CAP. CordLife India also holds an accreditation from NABL. CordLife has been proactively working with doctors and hospitals in various countries to develop an ecosystem to increase stem cell utilization. We've partnered with the University of Hong Kong, investigating therapeutic effects of umbilical cord MSCs on severe human influenza diseases in mouse models. In the Philippines, we are supporting Makati Medical Center's Center for Regenerative Medicine in a clinical trial using cord tissue MSC for diabetic foot ulcer and COVID-19. Locally, we are supporting KK Hospital's clinical trial using cord blood on children with autism spectrum disorders, a first of its kind to be conducted in Singapore. And now, also in Singapore, we are glad to be supporting Sing Health Duke NUS Academic Medical Center in testing the novel technology for the expansion of blood-forming stem cells from umbilical cord blood. This is the first in-man clinical trial in Singapore. This brings me to today's main topic. Although cord blood transplantation appears to be biologically superior to traditional sources of stem cells, the limited number of cord blood units with optimal dose has to be overcome so that more people can benefit from cord blood. Professor William Huang and his team from the National Cancer Center Singapore and Duke NUS have discovered a cord blood expansion technology aimed at overcoming, to some extent, this cell dose limitation to achieve better clinical outcomes and utility. After today's webinar, we hope you'll have a deeper understanding of how cord blood expansion technology works, the benefits of cord blood expansion, and the future potential of expanded cord blood. With this, I'm excited to introduce our key speaker for today, Professor William Huang. Prof. Huang is currently serving as the Medical Director of the National Cancer Center of Singapore, chairing the Oncology Academic Clinical Program of Duke NUS Medical School. He's head of SingHealth Duke NUS Cell Therapy Center and is also a senior consultant at the Department of Hematology at Singapore General Hospital. Internationally, he is an executive board member of the Asia Pacific Blood and Marrow Transplantation Group, regional vice president of the International Society for Cell and Gene Therapy. Widely recognized for his expertise in hematological malignancies, Prof. Wang has previously provided stewardship for multiple leadership portfolios, including Director of SingHealth Transplant, Head of SingHealth Duke NUS Blood Cancer Center, Head of Department of Hematology at the Singapore General Hospital, President of the World Marrow Donor Association, and Medical Director of the Singapore Cord Blood Bank. His clinical research focus is primarily on blood and marrow transplants, and he lends his expertise to numerous bodies in related fields. He has published over 100 clinical and scientific papers in his field, as well as 2 books and several book chapters. I would now like to hand the time over to Professor William Wang. Prof. Wang, over to you.
Thanks so much, Sarah. I hope you can hear me well, and really thank you for your very, very kind words. I'm going to try and share slides on my side, if I can attempt to do so. And really thank you for the kind words and the invitation to give this talk. Really my pleasure and privilege to be speaking on this subject, for which I hold very passionately, on the expansion of hematopoietic stem and progenitor cells from umbilical cord blood. So hematopoietic stem and progenitor cells are basically blood stem cells, which produce all the blood cells that you have that are absolutely necessary for life. Red blood cells are necessary to survive, to carry oxygen around the body. Platelets are necessary to help prevent bleeding. White blood cells to help us fight infection. Without any of these cells, we wouldn't last very long. And blood stem cells give rise to these blood cells throughout the lifespan of all of us. In fact, the mature cells of white blood cells or red blood cells or platelets do not last very long in the blood. And if not for the regular production of blood cells by blood stem cells, we would not be able to survive longer than a month or 2. However, these blood stem cells can also become bad. And blood cancers are cancers of blood stem cells. These are basically the blood stem cells, the hematopoietic stem and progenitor cells from the bone marrow. They can sometimes mutate and can become leukemia cells, lymphoma cells, multiple myeloma cells, as well as other types of cells that give rise to the various kinds of blood cancers. It's estimated that we'll have more than 1.85 million cases a year of blood cancers by 2040. And in fact, blood cancers seem to be on the rise. It's true that all cancers seem to be on the rise internationally, but some of the cancers, because of various control measures and things like that, incidences do not seem to be drastically increasing, even though they are higher in absolute number. Breast cancer, there is a gradual increase as well. But look at leukemia, the increase is rather dramatic, I would say, almost twice what it was back in 1998. The reasons for this are multiple. Blood cancers are what I call no-fault cancers. Most of my patients who come to me, when I ask them if they have any, do they smoke, do they drink, do they have any bad habits, or do any of their family members have blood cancers, the answer is usually 0, none. It's one of those no-fault cancers that no matter how we try to prevent, we can't seem to run away from. So as people get older, blood cancers will increase, no matter how intensive your preventive efforts. The other thing is possibly just as society as a whole and the world as a whole gets more urbanized, there could be more chemical substances, there could be more radiation in the environment, and that could also predispose to increase in blood cancers. One of the ways to cure blood cancers is a blood stem cell transplant, okay, through what we call hematopoietic stem cell transplant. And basically, we replace a person's entire blood forming system by giving him new sources of cells. Sometimes you can use this from the patient himself. You can take cells from a patient that hopefully are not contaminated with the blood cancer and give it back to the patient. Or we can take cells from someone else and give it to the patient. Each of these have its advantages. Autologous transplantation, being from the patient's own blood stem cells, is friendlier and easier to take. Allogenic transplantation from someone else has better control of leukemia, better control of blood cancers, but on the other hand, has increased risk because it's another person's blood cells, which could be rejected or it could also attack the patient. Now, blood stem cell transplants for blood cancers are curative for many of the blood cancers. And in some cases, it has been possible to kind of do a comparison between whether you had a transplant or whether you did not have a transplant. It's very difficult to do a randomized study of this sort, but there's a biological randomized study in the sense that many patients are not able to find a donor for transplantation. So some of the patients with this high-risk acute myeloid leukemia who were not able to find a donor in the past, did not undergo a transplant, and you can see that their survival is poorer compared to those who are able to find a donor for transplantation. And even patients with multiple myeloma that's relapsing multiple times, some of them appear to have a long-term survival. And every time the curve looks flat, these patients are potentially possibly cured. We can also use blood stem cell transplants to treat autoimmune disease, but primarily we use autologous cells, the patient's own blood stem cells, because we don't want to introduce another person's cells that might attack the patient. In these cases, blood stem cell transplants seem to be able to do a reset to the patient's immune system, to start it from scratch again, so that even in multiple sclerosis, systemic sclerosis, some of these diseases have been able to be had long-term control. I hesitate to say cure, but at least long-term control with these autologous stem cell transplants. Another thing is for some hereditary enzyme disorders, not the like diabetes and stuff, but hereditary enzyme disorders like Moore-Hurler syndrome. These are rare syndromes which can result in death. And what happens is the enzyme deficiency is in the blood cells. So when you replace with normal blood stem cells, then you can get rid of this enzyme deficiency. And you can see that many of these patients can be cured on the long term with these stem cell transplants. So currently, more than 60 years after the first stem cell transplant, the first stem cell transplant was in 1958. There are currently over 600 transplant centers in 60 countries and more than 60,000 transplants being performed every year. And over the years, survival has gotten better and better. And currently, I would say over 1.5 million stem cell transplants have been performed around the world. Singapore is one of the focal regional referral centers for stem cell transplants, as well as many other countries. And I think this is going to be continued to be an important curative modality for some patients with otherwise fatal blood cancers. Now, where can we get these blood stem cells? Since 1958, the traditional source was take them from the bone marrow. Cells are produced in the bone marrow, so you go to the bone marrow and you harvest. Actually, we harvest about 1 liter of bone marrow each time from the donor, and process the blood and collect and concentrate the blood stem cells and give it to the patient. You can also get it from the peripheral blood itself. These are collected by pheresis, and the cells are spun. White blood cells are separated, and the rest of the cells are returned to the donor. And this is a patient undergoing autologous peripheral blood stem cell collection, or subsequently autologous blood stem cell transplant. Another source is the umbilical cord blood. When the baby is delivered, the umbilical cord is clamped and cut in the usual way, and then umbilical cord blood is collected from the umbilical cord while waiting for the placenta to be delivered. And this has no harm to the baby, and it's also a very rich source of blood stem cells. So over the years, cord blood has had increased adoption, although that's somewhat plateaued over the recent years. The reasons for this is because cord blood transplants, for some reason, have a greater tolerance for mismatches. It's possible to do mismatch transplants, and consequently, once you are able to have a slightly mismatched transplant, it's much easier to find a match for transplant. It's like buying some kind of lottery ticket. If you have to match all 6 numbers of that lottery ticket, it's harder to win, right? But if you were told that it's okay, as long as 4 of the 6 numbers need to be matched, you will win the lottery. So that is what happens in a cord blood transplant. You can take 1 to 2 mismatches out of 6. And with the 1 to 2 mismatches, you have similar outcomes as a fully matched bone marrow or peripheral blood stem cell transplant with reduced graft versus host disease, reduced attack on the patient. Furthermore, cord blood, because it's banked, is readily available for immediate transplantation. Often when we are getting cells from another person, we have to do many things. We have to test if the person is really truly matched with the patient, double confirm it. And then we have to see when the donor is available for testing and screening to see if the donor is suitable to be a donor. And then subsequently, the donor kind of fixes a date that is acceptable to the donor based on his work and school schedule and stuff like that for the donation itself. And this period takes sometimes about 2 months or sometimes longer. Cord blood, however, is available immediately for transplantation. It's already in the liquid nitrogen tank. It's not going to run anywhere. And all the tests are already done. Some confirmatory tests still need to be done sometimes prior to the transplantation. And the quickest I've seen is when we had a patient that needed an urgent cord blood transplant on a Friday, and we immediately activated some further testing for the patient as well as the cord blood unit. And we started the patient on conditioning, and by the subsequent Wednesday, the cord blood transplant was executed and the cord blood was infused. So that's very, very quick. Furthermore, if you want to do autologous transplantation, often you have to make sure that the patient is in remission of the disease. You have subsequently to collect and arrange for collection and harvesting of the cells from the patient himself. And then subsequently, after the patient is recovered, then you undergo high-dose chemotherapy and reinfusion of the cells. And that takes quite a while. Whereas if you have autologous cord, that becomes readily available. In this study published in the New England Journal of Medicine, I apologize for not putting the reference below, but basically it was published in the New England Journal of Medicine about 3 years back. It's a comparison between cord blood transplantation versus fully matched bone marrow donors and mismatched unrelated bone marrow donors. Now, cord blood is in black in terms of survival. You can see that survival is excellent compared to fully matched adult bone marrow donors and better than mismatched adult bone marrow donors. Sorry, let me go back 1 slide. The reasons for this appears to be that the cord blood transplants have lower relapse rates compared to this fully matched bone marrow or mismatched bone marrow. And the reason for this was actually, the results were actually quite surprising because a number of people at the time thought that cord blood cells are friendly to the patient. They don't attack the patient. They don't, well, they do, but they have much lower rates of graft versus host disease, much lower rates of immune attack against the patient. So a lot of people felt that it will also have lower attack against leukemia cells. But on the other hand, cord blood cells, although they are friendly to the patient, appear to be unfriendly towards cancer cells. And this was good to see. And you can see, furthermore, in patients who already have some degree of minimal residual disease at the point of transplantation, that means they still have a trace of leukemia cells at the point of transplant, this anti-cancer effect for the cord blood grafts appear to be even stronger. And you can see even more dramatic reduction in the relapse rate in this particular group. So it becomes even more obvious. Consequently, if a patient is going through transplant with still some residual disease at the point of transplantation, cord blood transplants appear to have a better survival in patients with this minimal residual disease. However, not everything is hunky-dory for cord blood transplantation. And the reason for this is that cord blood grafts result in a slower blood count recovery. if you compare with peripheral blood stem cell transplantation, which traditionally recovers their counts at 14 days after transplant, or bone marrow in 18 days, cord blood grafts usually recover about 25 days after transplantation. And this extra week to 2 weeks results in higher risk of infection, higher risk of transplant-related mortality due to various complications that can occur due to the low blood counts during this period of time. On the other hand, these problems can be overcome in part due to a higher cell dose at the point of transplantation. And in patients who receive a high cell dose at the point of transplantation, mortality is much lower, whereas those who receive a low cell dose at the point of transplantation, mortality is much higher due to delayed blood count recovery, delayed immune reconstitution, and increased graft failure. So a high cell dose is absolutely important at the point of transplantation. And transplant physicians, when we choose a cord blood graft for transplantation, we always try to choose the cord blood unit that has the highest number of cells for transplantation that is adequately matched to the patient. So what if you could grow these cells, increase the number of cells for transplantation? It's not so simple, because growing mature cells is quite easy. And you can grow mature cells and they will last maybe a month, 2 months, 3 months, and then they will start to fade away because they are not the long-lived blood stem cells. Growing the true blood stem cells is tough. And these are phenotypically, that means based on cell surface markers, as well as functionally defined on mouse engraftment and otherwise. However, we've had participation in a recent international multi-center trial. This is called the NICOT trial, and run by this company called Gamida Cell. And in this particular study, the cord blood grafts are separated into 2 fractions. So one which is the stem cell-rich fraction, which was cultured for 21 days and then given to the transplant center, as well as the negative fraction, which is co-infused at the same time. What was extremely interesting in this study is that the cord blood grafts that were expanded were able to sustain engraftment on the long term. They could even outcompete another unit that was given at the same time to the patient that was not expanded. And engraftment is no longer 25 days. In fact, this is the best results for the control. Control was 21 days. But even then, the expanded cord had engraftment of 11 days after transplantation. And this was sustained. I've had patients go through it, and they're still well engrafted many years after. Furthermore, this days alive and out of hospital after the transplantation was better with the expanded cells versus non-expanded. So basically, days hospitalized was much less with the NICOT protocol. And the results have been recently confirmed in a phase 3 study that's just been published. What we have found is that we could improve on this process. And one of the issues about this, the previous study, is that even though we were able to help a number of patients, but the selection criteria for the cord for that that study needed quite a high dose of cells for the selection of the cord for transplantation. So we were kind of limited in the cords that we could select for the patient. So I will show a little bit about what we have done. And we found a novel small molecule that enhances blood stem cell graft manufacturing. The limitations of current competing technologies is that it requires a prior selection of CD34 stem cells, a high dose of 34 cells. Some of these expansion techniques seem to support the growth of leukemia cells, and safety profile is not so clear. We found a novel small molecule that's been shown to be safe by a variety of techniques, and also has good expansion of these CD34 progenitors. And when we transplanted them into mice, we also found that there was much better engraftment with the expanded cells. And not only that, the expansion was sustained when we took the cells out of the mice after 6 months of transplant and implanted into another mouse. We also compared it against current technologies, including the nicotinamide technology, and found that it did better in vitro compared to all these other techniques. And we've also looked at the mechanism of actions in great detail. So the current technology we found does not require prior selection of the stem cells, does not require a very high dose to obtain significant expansion. And also, which I did not show here, when we put it into culture with leukemia cells and things like that, it was actually, does not support the growth of leukemia stem cells. And in fact, maybe even detrimental to the leukemia cells. So, sorry, this is the data showing that it does not expand leukemia stem cells and may be detrimental to it. So in this stem cell technology, we have a proven stem cell phenotype, accelerated and sustained engraftment in animals, mechanism of action studies, and safety and toxicity studies have been performed. We performed it against other industry standards, and it appears to be superior, highly potent compared to the others. And the only thing is bringing this to the clinic. So subsequently, we have to do large-scale manufacturing processes for cell selection, cell thawing, cell culturing, cell washing on a large scale that we're collaborating with the Advanced Cell Therapy Research Institute of Singapore to bring it into clinical trials. And the clinical trial will be run by Dr. Francesca Lim from the Department of Hematology in Singapore General Hospital as study PI. And this will be a first man clinical trial that is supported by Singapore Duke NUS, CordLife, and the National Medical Research Council. They were very grateful for this public-private partnership to allow this early phase clinical trial. It allows de-risking of technology by obtaining clinical safety, efficacy, and manufacturing feasibility data. And I think this is a good way forward as we look at now public-private partnerships and how we can bring scientific aspects as well as industry players into cooperation. Now, the implication of this is actually tremendous for cord blood banking, whether public cord blood banking or private cord blood banking. And the reason for this is that there are many cord blood units stored in cord blood banks around the world, whether in private cord blood banks or public cord blood banks. And this is kind of a bell-shaped curve of how the cell dose on the horizontal axis, the cell dose of the unit, and the number of units of that particular cell dose. However, at the lower cell doses, there's hardly any utilization. I would say that in this range right now, it's gotten even less than 4% maybe utilization. And most of the cord blood units in cord blood banks around the world are like this. Even if we increase the cell dose, the utilization is about 14 to 18%. Of course, in the very high cell doses, there's a lot of demand for these units. Now, this is a problem because it's a mismatch between supply and demand. So, however, if you can have just 2 to 3-fold expansion of the nucleated cells that are truly blood stem cells, you can push many of the units into the high rate utilization zone and become much more useful for patients for transplantation. So we are really looking forward to this to be of benefit to patients and also be of benefit to cord blood banks around the world. But other indications for stem cell expansion that goes beyond cord blood are as follows. One is, what if we have insufficient cells after a bone marrow or peripheral blood stem cell harvest? And sometimes we need this because you need lots of cells from the patient, or the patient is heavily treated and are not able to harvest enough cells for transplantation. So this gives us an opportunity to give us enough cells. Also, if we are able to grow blood stem cells, we can use it as a platform for gene therapy to expand the cells after genetic manipulation. And so potentially we could use these cells as off-the-shelf therapy to reduce the period of neutropenia after intensive chemotherapy. So with that, I'd really like to thank you, especially some of my lab members, particularly Dr. Sudipto Bari, whose work went into the discovery of many of these. This is my collaborators, Christina and Gigi, who were vital in putting forward this C7 technology, as well as our collaborators in Joint CTAD, Duke NUS Medical School, and particularly Dr. Francesca Lim, who is the PI who's going to spearhead this clinical study going forward. Thank you very much, and really appreciated being able the opportunity to give this talk. Thank you.
Thanks, Prof. Wang. Right. Yeah, thank you so much for for sharing about these super exciting advancements surrounding cord blood. I think we are just going to move on to the next section of today's program. And I just want to give all our attendees a bit of a reminder. If you do have questions, please remember to key them into the chat at the bottom by clicking on the bottom of your screen. We are not really using the raise hand function today, so all questions will be addressed within the chat. Okay. Our next section is it's a section by Dr. Arvin Fondo. He's our Cord Blood Bank Director of Cord Life Singapore and Medical Director of Cord Life Philippines and Indonesia. And he's actually going to be sharing about some of Cord Life's latest clinical and product updates. So with that, I would like to pass the time over to Dr. Fondo.
Thank you, Sarah. Can you hear me well?
Yeah, good.
All right. So good day, everyone. Thank you for joining today. And I'm here to give you some updates. First would be on the trial for autism, and the second would be our new offerings. So first, I'll give an update on the Singapore autism trial. Next. So this trial is being conducted in Singapore KK Women's and Children's Hospital, which, as you may know, has been around for more than 100 years. And it's Singapore's leading hospital specializing in obstetrics, gynecology, pediatrics, and neonatology. Today, the 830-bed hospital is a referral center providing services to manage high-risk conditions in women and children. So, as some of you may know, the hospital has initiated a clinical research on the use of autologous cord blood infusion for treatment in children with autism spectrum disorder. So the purpose of this study was to determine if umbilical cord blood stem cells can improve the symptoms in this disorder. This study was meant to last for about 20 months with 7 study visits involved. And this would need blood tests to be carried out and a 1-day admission to the hospital for the child's cord blood to be infused back. And there would be repeated psychological tests to assess the severity, behavior, adaptive skills, and IQ, as well as eye tracking assessments before and after infusion of the cord blood. Next. But not all children would be eligible. So for those who are unwilling to commit for follow-up for that duration of time, for those with a prior history of cell therapy, those who have used immunoglobulins or other anti-inflammatory medications, which can interfere with the study, those with genetic abnormalities as well as dysmorphic features, those with active CNS infection, those with epilepsy or uncontrolled seizure disorder, sensory or motor impairments, uncontrolled infection like HIV, as well as active malignancy. Next. So we're very happy to be part of this trial, which looked into the safety and efficacy of autologous cord blood infusion. So as a group, we have distributed cord blood coming from 12 clients, 11 coming from Singapore and 1 from the Philippines. So after much coordination and before the release of each cord blood unit, quality assurance tests were carried out, and with the approval of the trialists, before these samples were sent to the hospital in order to participate in the trial. So all our clients who were admitted were successfully infused with their own cord blood for this trial. Next. So these are the details of the samples released by CordLife for this trial. So as you can see from the table, there are 12 participants from our side, and they were infused from July of 2019, and the last one was in August of last month. So all of them had a diagnosis of autism spectrum disorder, and the total nucleated cell counts were acceptable based on the study design. And most of the units used 100% or all of the units that were preserved, except for one that would be number 5 here, which used only 80% to qualify for the study, meaning that 20% is left behind that may still be usable for other uses in the future. So many of these units were kept for about 4 to 5 years. The youngest was 3 years and 9 months. That would be number 10. And the longest was 5 years and 7 months. That would be number 1. So this is a snapshot of the samples that we have released for this autism trial. Next. Next, please. So the other update would be the new product offering from CordLife, which we call OptiQ. OptiQ is CordLife's corneal lenticule banking service that's offered to patients who choose to have laser vision corrective surgery, particularly SMILE, for correction of myopia and or astigmatism. So this is a patented technology that is exclusively licensed from Singapore's Eye Research Institute under the SingHealth Group. And this has the approval from the Ministry of Health in December of last year. And this was officially launched in Singapore in February of this year. Next. So for those of you who may be familiar, there have been many advances in laser-assisted refractive surgeries. Early on, there was photorefractive keratectomy or PRK, but the problem here was the long visual recovery and accompanied by discomfort. And many would be familiar with LASIK and LASIK, wherein there is quick visual recovery. However, there is the risk of flap-related effects, and many patients would complain of dry eyes. And more recently, there is RELEX, SMILE, or refractive lenticle extraction, small incision lenticle extraction, which offers generally fast visual recovery, and treatment has a very small incision. Next. So what is SMILE or small incision lenticle extraction? This procedure would remove the lenticule, and as you know, the lenticule is a disc-shaped corneal tissue, or it may be a piece of synthetic material that is manufactured to produce a given curvature and thickness. And this is implanted into the top of the cornea to change the curvature. So the advantage using a biological lenticule over a synthetic one is that it offers superior biocompatibility that leads to faster recovery. It also carries a low risk of rejection and avoids the risk of corneal inflammation and scarring. And in the future, reimplantation procedure can be easily reversed. Next. So there have been many lenticule reimplantation trials in the past, and this involves different eye conditions like hyperopia, presbyopia, keratoconus, etc. And these are all listed here. So this forms the basis of this particular studies. Next. So how are corneal lenticles collected and stored? So first, after the procedure, wherein the corneal lenticles are extracted, these are then delivered from the clinic to our laboratory. And then blood will have to be collected from the patient. And the lenticles will be processed in the laboratory and cryopreserved. Next. So that would be the updates for this afternoon. And as you can see here, they are the eye experts who are working, we are working with for this particular new offering. Thank you very much for your attention.
Thank you, Dr. Fondo, for the updates. Now we are going to move on to our Q&A session. Again, please feel free to enter your questions into the chat box below. I think we have a few questions already, so I'm just going to start firing them off at either Prof. Wang or Dr. Fondo. Hang on. All right, let's see. Okay, this question. Okay, this question, I think it's for Prof. Wang. Okay, in terms of nucleated red blood cell yield and cost effectivity, how does a source for expansion from mesenchymal cord cells compare with that from cord blood?
That's an excellent question. And in fact, many years ago, we did do a clinical trial expanding cord blood cells in conjunction with mesenchymal stromal cells. And we found that the results were modest. And it was hard to say whether it was more effective or not more effective at that point of time. So we did not continue that study, but there was some limitations pertaining to the use of mesenchymal stromal cells, and we actually found it less cost effective for a few reasons. One is I had to make sure that I timed the mesenchymal stromal cells to be kind of ready at the point with a confluent stromal layer before I seed the cord blood cells for transplantation. And that added more to the manufacturing time that was needed for expansion, and that sometimes caused delay for the patient. The other aspect which I had not counted on was that I actually had to use much more media when I was expanding in conjunction with mesenchymal stromal cells, because every mesenchymal stromal cell needed a confluent layer on at that time was a T175 flask, and we needed quite a number of these to have sufficient layers to seed the cord blood cells on the mechanical cord blood unit. In fact, close to about 20 to 40 flasks. And consequently with that, a lot of media was used, and the media was expensive. So we did not pursue that. And plus another factor that has turned out to be important in the more recent cord blood expansion is that when we can keep aside some of the non-stem cells, the non-CD34 cells, and use these as immune cells at the point of transplantation, these seem to help the cord blood unit by providing kind of an immunological protection for that cord blood unit. So it's a bit long answer to a short question, but it's something that we did before and we were very enthusiastic about. But at that point of time, mesenchymal stromal cells did not turn out to be what we wanted to be for helping cord blood expansion. But these new methods we're very excited about because the results are so much better than what we've seen before.
Thanks, Prof. Wang. Okay, the next question, I think this is also for Prof. Wang. Since cord blood expansion technology is not yet commercially available, what can parents do if their child's bank cord blood unit has insufficient cells?
This is from, I'm trying to find who it came from. Sorry, I didn't see it. Anyway, okay, so it is an issue, if it's insufficient cells. For one, there are many considerations that we can have. One is that there are many cord blood units banked in public cord blood banks around the world. That could be one potential source. And if that public cord blood unit has insufficient cells, and many such units may be insufficient cells, sometimes it can be combined with another unit. And if the child's own unit is deemed to be acceptable in combination with the other publicly banked cord blood unit, and this may be used in what we call pooled cord blood transplantation, where the two cord blood units don't seem to attack each other and seem to have an additive effect for the patient. So I hope that partially answers the question. But in future, with cord blood expansion, maybe, especially if we can do it more reliably and with lower cell dose of cord blood units, that would be an exciting future ahead.
Thanks, Prof. Wang. Our next question is, okay, this is also one from one of our ONGs. I think it's a question about blood volume, cord blood volume during the collection. It's very related to our ONGs. Is there a minimum?
Okay, so I see the question from Tony. Tony, you always ask very difficult and very good questions. So I'll attempt to answer this. The fact is, at the point of transplantation, as transplanters, we will choose the cord blood unit with the highest cell dose. So we will want to have, even if it's going to be expanded, we want to make sure it's the highest cell dose unit prior to expansion, so that we have the best possible results for the patient. Because you know that cell dose matters so much. So Singapore, we say money no enough, but this is cells not enough for cord blood. We just want as many as possible. So I would say that the minimum volume is set according to different cord blood banks, according to, firstly, what is possible to be processed reliably. Because if it's below a certain volume, there's too much of the diluent, and you can't process it properly, and you have a very improper collection, improper processing. Also, if the volume is really, really too low, there's also the question of whether it has enough stem cells inside that particular volume for there to be even a reliable expansion. So that becomes a potential question. Nevertheless, we don't know what the future will hold, because what we are seeing, at least in our preclinical studies, looks really interesting in what we can do from very few cells. So the future could be different. But I would say, at least for the moment, please collect as much cells as possible that you can, because transplanters, we really want as much cells as possible for transplantation.
Thanks, Prof. Wang. The next question, let's see.
I think that's
okay.
all the question.
Yeah. I think we've got some also of our doctors messaging us separately to some of our staff, so it might not show up in the chat. Hang on. Okay, so this one is also for you. How unique is C7 compared to other cell expansion technology currently in clinical trials?
Yeah, well, I think C7 has, as I outlined, one of the things is that it does not require CD34 selection at a point, and it's very robust in terms of its cell expansion. Whereas when we use the other techniques, we find that we always need some degree of stem cell selection before the expansion process. What's also important is that when we tested it against leukemia cells, it does not grow leukemia cells. And some of the other technologies that we explored, they did not necessarily have that kind of benefit that we saw. So I think these are the two of the key advantages that we have. Also, in terms of the level of expansion, we seem to have a greater level of expansion, even when we have a number of collaborators and we collaborate with them to see how our technology does in combination with theirs. And at least in all the in vitro studies, it seems to outperform these other technologies, even though it can actually complement some of these other technologies as well.
Thank you, Prof. I think, okay, our next question is for Dr. Fondo. Okay, this question is, Dr. Fondo, will KK Hospital be conducting a phase 2 or 3 clinical trial using the cord blood to treat autism?
Right now, we do not have that information yet, but we are eagerly awaiting the results of this trial, and hopefully we move on to phase 2, or they move on to phase 2 or 3.
Okay, thanks, Prof. Thanks, Dr. Fondo. And then one more. Okay. Will Cord Life be running similar autism trials with cord blood in other countries? I think this is also for Dr. Fondo.
So we'll be very happy if that would be the case, and we would really encourage our participants from the different countries to also have a trial like this in coordination with this institution, or even in your own localities.
Okay, thank you, Dr. Fondo. And okay, I just got another question. This one is for Prof. Huang. Will subsequent clinical trial phases using C7 compound for expansion of HSPCs be done in other countries?
Yes, we would like that to happen. It's just that usually when we start a clinical trial, we keep it a single site, and to de-risk it, so make sure that with all the factors well controlled. And then subsequently, hopefully, my aim is that every patient that receives a cord blood transplant should have some kind of cord blood expansion, particularly when the cells are insufficient for adults. And I think that would change the face of cord blood transplant and make it so much safer. So that's certainly something we'd like to see.
It's exciting. Thanks, Prof. Huang. And our next question, and I think we're back to MSCs again. So there's a question that says, how about the MSCs from umbilical cord that are cultured in hypoxic conditions these days? Because there are quite a lot of studies are going on about it.
Yeah, I think that's interesting. I think it's worth looking at. I think MSCs is something I'm not doing a lot of focus on currently because of issues with my previous study. But I'm looking at ways of replacing the MSCs currently, finding better ways than using the MSCs themselves. But MSCs do have a strong role, I think, still for many regenerative medicine purposes and otherwise. So I think it's worth looking at. Hypoxic conditions seem to be important for keeping cells in a stem cell-like state.
Okay, thanks, Prof. And our next question is actually, okay, now we're back to Dr. Fondo. Will allogenic transplants for autism be considered as part of the trial moving forward? This one is for Dr. Fondo.
Allogenic, you mentioned.
Allogenic, yes.
Yes, in fact, that has been carried out already in Duke University. So after they have established the safety and efficacy of autologous cord blood, they have moved on to the use of allogeneic cord blood. And that is really important to consider, because some patients would not have their own cord blood stored. So an allogeneic source, likely from a sibling, is another option that must be considered.
Thank you, Dr. Fondo. And this one, okay, this question says, is there any role for Hscts in hereditary hemochromatosis? I think this might be for Prof.
Yeah, maybe I'll take that. It's hereditary hemochromatosis is basically a defect in the utilization of iron. And it's not so much a blood stem cell issue, it's actually more like a liver type of issue. So blood stem cell transplants are not useful in that. In fact, but the prognosis for these patients can be pretty good as long as you keep with venesection or iron chelation.
Interesting. Thank you, Prof. And okay, I think we're on to our last question because we're running out of time. Last question is, okay. Can stem cells be used in manufacture of vaccines? I think vaccines are a hot topic right now.
Okay, so there are several kinds of vaccines. There's, as we all know, right? You have virus vaccines, and now you have mRNA vaccines and things like that. But I think there's another category of vaccines that are not your traditional vaccines, and these are your cellular vaccines. And we have used things called dendritic cell vaccines, or T cell, basically primed cells that have been loaded with antigens that you give to the patient, so that these cells would present antigens that stimulate the body's immune system. And stem cells can grow some of these antigen presenting cells as a source for that. But you might not need stem cells to do that, because you can also get these antigen presenting cells with other methods.
Okay, thanks, Prof. Oh, sorry, we have one more question that came in. Okay, I would just like to take the time now, before I go into the next question, to announce that the seminar proper is actually now over. For those who need to return to your clinics, doctors, please feel free to do so. We hope you have enjoyed today's seminar and hope to see you soon. For those who are able to stay, please feel free to stick around, and I will continue with the next question. Right, our next question is, where's my, I think this one just came into the chat. Is cord blood used for MS studies, and would this be allogenic?
MS, I presume, is multiple sclerosis.
Multiple sclerosis, I believe so, yeah.
If it's multiple sclerosis, usually when we do a transplant for multiple sclerosis, is an autologous transplant for multiple sclerosis. We haven't done allogenic transplants for multiple sclerosis yet, because of the increased risk of the procedure. We haven't used autologous, we haven't used cord blood for multiple sclerosis yet, at least in our center. I know that there are other centers looking into the use of it, and they may have done 1 or 2 in clinical trial setting, but I'm not really aware of those results. But however, the premise of using autologous cord blood is interesting, because the cord blood would usually be many years before the patient developed multiple sclerosis. And this will be before the T cells have acquired a autoimmune characteristic to the T cells. So using autologous cord could be an interesting way of doing transplantation for multiple sclerosis. But I haven't seen the data for that, and I'm not sure if any clinical trial has been done in that regard yet.
Thanks, Prof. Okay, and then one more question. What is the update of stem cell for treatment of diabetes? Is there any? Either Prof or Dr. Fondo, please go ahead.
Oh, yeah, let me take a shot at that. There have been studies using cord blood for type 1 diabetes. As you know, it is an immune disorder. So they have tried using cord blood for that. However, for type 2 diabetes, there are studies using cord blood for the complications of type 2 diabetes, but not for the disease itself.
Thanks, Dr. Fondo. I believe that's all the questions that we have right now. Okay, and I think we will wrap it up. Thank you so much, Prof. Wang and Dr. Fondo again. And thank you to the ONG societies for your support today, as well as all our doctors for joining us. We hope to see you again. If you do have any more questions, please feel free to message your country rep, and we will get back to you. Thank you so much.
Thank you.
Have a good afternoon.
Bye.
Thank you. Bye.